rolling start. Christina, would you like to welcome us again, just for folks who have tuned in a little bit later and missed your first welcome?
Yes, of course. Thanks, Celeste. Sorry, I've got a participant trying to get in. My name is Christina Coates. I'm the president of the Hypertrophic Olivary Degeneration Association. We are the only patient group that deals with hypertrophic olivary degeneration. We are thrilled to be partnering with NAF today on this webinar, and we're so grateful to Dr. Shakkottai. I'm sorry, I always say it wrong. Dr. S for agreeing to do this for us. We believe this is the first time a webinar dedicated solely to HOD has been put on, so we're very grateful for this. And welcome. Thank you for joining us. We appreciate it.
And my name is Celeste Seward. I'm the Patient Engagement Manager for the National Ataxia Foundation. And again, we're echoing Christina's words. We're so excited to have you all here today and to have our speaker here today. Before we dive into the talk, just a few housekeeping items to make sure everyone gets the most out of this session. First, if you need closed captions in order to better interact and understand with what is going on, you can turn that on at the bottom of your screen. And if you'd like to connect with other people who are attending the session, other members of the HOD community, please feel free to use the webinar chat like we just did when we were sharing where we're coming from today. If you have questions for our speaker, though, we ask that you use the Q&A window at the bottom of your screen. So you can find that. It has a little Q&A on it. Please put your questions there. Please don't type them in the chat. Sometimes those can get lost, and we want to try to get to as many questions as possible. So thank you in advance for putting your questions in the Q&A window. And with that, it is my absolute privilege to introduce our speaker today, Vikram Shakkotai. He obtained his medical degree at the Christian Medical College in Vellore, India, and his Ph.D. at the University of California, Irvine. He received his neurology residency training at Washington University Barnes Jewish Hospital and was a fellow in movement disorders at the University of Michigan. He joined the full-time faculty at the University of Michigan in 2010, and he moved to UT Southwestern in 2021. The long-term goal of Dr. Shakkottai's clinical and laboratory research is to determine whether alterations in neuronal physiology contribute to motor dysfunction and to translate preclinical murine model research, that's mice, to human clinical trials for cerebellar ataxia. Work in Dr. Shakkottai's lab has identified a shared dysfunction in cerebellar murine models of ataxia with the identification of several ion channels that act in concert and converge on large conductance calcium activating potassium BK channels. BK channels are likely a key therapeutic target for degenerative ataxias. Dr. Shakkottai also happens to be on both the advisory board for the National Ataxia Foundation and the HODA. And with that, I will turn the floor over to Dr. Shakkottai.
Thank you, Celeste, and thank you, Christina. It's nice to see both of you, and it's a real pleasure to speak about hypertrophic olivary degeneration. I want to highlight, I think, my clinical experience with individuals with ataxia as well as HOD is really what motivated and motivates the research in my laboratory. And I know Celeste kind of talked a lot about kind of calcium activated potassium channels. So that does actually may have a potential role in understanding HOD as well. So without further ado, I'm going to dive into the talk. And I guess if someone has questions, Celeste, you'll probably let me know. And I want this to be interactive, and I want people to interrupt if there's something that they're not kind of following. There it is. So this is the outline of my talk today. So what is HOD? Symptoms associated with HOD, or and I'm abbreviating hypertrophic olivary degeneration as HOD. Applicability in what's called OPCA, or olivopontocerebellar atrophies, that includes spinocerebellar ataxias such as SCA1, SCA2, and some other, including others like SCA7. And I'm going to talk about the etiology and kind of the my view of the clinical experience of individuals with HOD, and what potential management options there are now, and potentially what the research will tell us about in the future. So just to introduce the olivary nucleus. So the inferior olive, so on the right, you can see a sagittal view of the human brain. And what you can see is the brainstem region. And on the right portion, you see the cerebellum, and the cerebellar cortex has these neurons known as cerebellar Purkinje cells. And there's nuclear neurons, or cerebellar, deep cerebellar nuclear neurons, which are really important in relation to the inferior olive. So the inferior olive is a brainstem nucleus in the medulla part of the brain that is intricately connected with the cerebellum, and is a really important, and has been recognized to be an important part of the cerebellar circuit, and perturbations in the cerebellar circuit are well known to cause ataxia. So on the left side of the screen, in the label, the panel labeled B, you can see the inferior olivary nucleus in humans. It's a paired nucleus, meaning there's one on each side of the medulla and the brainstem, and lies just posterior, or just behind, the corticospinal tracts, the tracts that provide motor commands to the limbs. And it's a kind of has this curvilinear shape, almost like a tooth in a three-dimensional shape. But it's called the olivary nucleus because there's a characteristic bulge in the brainstem medulla that looks like an olive, and therefore it was called the inferior olivary nucleus. It was what is HOD? HOD was is when this olivary nucleus becomes larger, and hypertrophy is just another word for an increase in the size of the olive. It was first actually described way back in 1889 from some German neurologists, where patients' brains at autopsy were identified to have these enlarged enlarged olivary nucleus. There was a lot more work looking at the clinical relationship between olivary hypertrophy and some clinical symptoms that was really described by a group of French neurologists who were successors of a very famous French neurologist, Charcot. Others, such as Guyan and Molleret, also French neurologists, really defined a syndrome that I'm going to describe in the next few slides. And this was in the 1920s. This is what HOD looks like when you look at a human brain. This is from a study in 1981 from individuals who had a brainstem bleed, which I'm going to talk about later as how this causes HOD. But what you can see from the very first slide was the two paired olivary nuclei in the brainstem. And what you see in some of the slides, particularly in the bottom right, as well as the one just above it, is a very large increase in the size of the olive, as represented by a thickness in this curvilinear shape of the olive on the in the bottom right, for example. It's more prominent on the right side compared to the left side, but you can see enlargement in the olive in both sides. So this represents olivary hypertrophy. So what is the difference between olivary hypertrophy and hypertrophic olivary degeneration? They're now used synonymously, and the reason is as part of this process where the olive gets enlarged, there is also degeneration that follows. And therefore, the terminology is for a spectrum of hypertrophic olive that then also degenerates. And by degeneration, I think it's important to kind of define what that means. It's the loss of neurons within the olivary nucleus. So the olive contains these nerve cells that are connected to the cerebellum. And during at least the initial stages of HOD, there is an enlargement in the size of the neurons within the olive, but no loss of those neurons. And then at later stages, there is a loss of those neurons as well. And therefore, this continuum of changes, when there is an increase in the size of the olive, is known as hypertrophic olivary degeneration. So this can be seen also using a brain MRI. This is a case report that was published in 1994, which represents, I think, one of the more common causes for hypertrophic olivary degeneration, and this is a bleed within the brain stem. In this case, the bleed, which you can see in panel A, shown by the arrows pointing to that dark area on the left side, is in the region of what's called the superior cerebellar peduncle, which is the connections between the cerebellum and the inferior olive. And that results in this enlargement in the size of the enlargement in the olive seen in panel B, which is this area of kind of increased white signal in the medulla on the left side of your screen. And the reason for the hypertrophic olivary degeneration is thought to be loss of this connection between the cerebellum and the inferior olive. And the actual causes, I'm going to kind of explain further, because I think it is important to understand from kind of a thoughts about why some of the clinical phenomenology happens with hypertrophic olivary degeneration. HOD is not exclusive to humans. You can produce HOD in cats, and this is shown over here. This is from a group in the Netherlands that published this report in the 1960s, where you can see again, although the olive doesn't look quite as big and convoluted in cats as in humans, you can see the olivary nucleus on the two sides in the cat, and you can see a significant enlargement in the in one of the subnuclei within the olive on the right side. And this was produced by a lesion that destroyed the cerebellum on the other side. So what we know from these studies in cats is that the basis for olivary hypertrophy and the subsequent hypertrophic olivary degeneration is a destruction of the inhibitory connections from the cerebellum on the opposite side as the inferior olive. So this lesion in this cat, for example, the hypertrophic olive is on the right side, and the destruction was of the left cerebellum, left hemicerebellum. So in order to understand kind of what hypertrophic olivary degeneration does clinically, it's important to understand a little bit about what the inferior olivary nucleus does. So what you can see here are recordings from in this case, actually a mouse, where you can see these little lines along this kind of thicker line. So each of these lines represents what's called an action potential or spike in the cerebellum. And these are recorded from cerebellar Purkinje cells, which are the major cells in the cerebellum that encode motor information. And you can see two kinds of spikes that kind of stand out on the top trace that kind of stick up over the little spikes that are in the background. And these bigger spikes are called complex spikes, as opposed to the other spikes, which are called simple spikes. And the complex spikes are generated by the inferior olive. So this is the most important thing from a neuronal circuit standpoint that the inferior olive does. It generates these complex spikes. Now, what are complex spikes good for? We think that complex spikes are really important for cerebellar learning. So the olive is one of the most important mediators of cerebellar learning, and at least in animal models, when the signals from the olive are destroyed, there's a profound inability for motor control that manifests as ataxia and inability to learn motor tasks. In patients where there is hypertrophic olivary degeneration, remember the problem in HOD is not directly due to damage to the olive, but due to a damage in the connections between the cerebellum and the olive and how they communicate with each other. And in a subset of patients, and it's not at this point entirely clear why some patients manifest these symptoms, the characteristic clinical syndrome is an oculopalatal tremor. And I'm going to play this video. And this is also called oculopalatal myoclonus.
This is a patient with oculopalatal myoclonus. Note the rhythmic beating of the eyelids that matches the same rhythm as the eyes, which are moving in a mostly horizontal, but also sometimes torsional and sometimes a little bit of vertical. So here you can also see the rhythmic movements of the palate, and you can hear and see her breathing, which is rhythmic in the same rhythm as the palate and the other motions. And there are also rhythmic motions of the face here, and the same rhythmic motion of the neck. So all of these are moving together.
So in addition to oculopalatal tremor, there is an association. I will say that the clinical phenomenology associated with hypertrophic olivary degeneration is somewhat poorly described and even more poorly understood. But there are other palatal tremor syndromes beyond oculopalatal tremor, but characteristically, the oculopalatal tremor becomes symptomatic as in a delayed fashion, and not immediately after what typically happens, which is a brainstem hemorrhage. So the characteristic clinical course in the development of HOD and oculopalatal tremor associated with HOD is there's a brainstem hemorrhage that often in the region of the superior cerebellar peduncle or in the midline portion of the brainstem in a region known as the central tegmental tract, that in a delayed fashion, often months after the hemorrhage itself, causes worsening of ataxia and the development of a tremor, which is manifested as this oculopalatal tremor. The peak of the oculopalatal tremor is often between 5 and sometimes as long as 24 months after the original injury. Once established, the palatal tremor or the oculopalatal tremor often persists for life. But there are a few patients where there's an improvement after many years, even though the MRI shows this persistent change in the signal in the inferior olivary nucleus. There are other syndromes associated with HOD, including progressive cerebellar ataxia. So there are syndromes of progressive cerebellar ataxia associated with palatal tremor, and in many of these cases, there's no structural brainstem or cerebellar lesion, but the cerebellar atrophy on the MRI progresses over years. There's another group of conditions where there's not a well-described hypertrophy of the olive known as oculopontocerebellar atrophies. So these were, again, first described in the early 1920s and further characterized in the 1980s. But now we have a genetic diagnosis for many of these. And the genetic forms of olivopontocerebellar, and the reason it's called olivopontocerebellar atrophy is that there is a characteristic degeneration in the inferior olivary nucleus, in addition to ponto, which is the pons, and the cerebellum. And these are now reclassified essentially as genetic forms of ataxia, including spinocerebellar ataxia type 1, which is considered the most characteristic or canonical inherited OPCA. But there are also non-inherited forms of olivopontocerebellar atrophy, including multiple system atrophy of the cerebellar type. So a number of other conditions can cause degeneration in the olive, even if they don't produce a characteristic radiologic or pathologic changes in the olive, at least at autopsy in end-stage disease with olivary hypertrophy. So we undertook a research study in a mouse model of spinocerebellar ataxia type 1 with Logan Morrison, who's a graduate student in my laboratory, to try and identify vulnerability to degeneration in the olive in spinocerebellar ataxia type 1. And to our surprise, we actually discovered, at least in this mouse model, that there were changes in the olivary neurons that were very similar to what's been described both in humans as well as in cats with hypertrophic olivary degeneration, or HOD. So in this mouse model, just an illustrative figure, so what you can see is this very large increase in this dendritic arbor, and we also showed that this is followed by an increase in the size of the cells themselves, so the soma size, and that in this case we found changes in what's called the intrinsic excitability of these neurons. So what you can see on the left is a wild-type inferior olive neuron, where in this mouse, we're able to record from those neurons directly and measure their electrical activity. And you can see that the SCA1 mouse olivary neuron generates a large number of spikes, unlike the wild-type mouse. So what we are investigating now, at least in this model of SCA1, is if this is a common mechanism. So I told you the most common cause for hypertrophic olivary degeneration, at least in humans, is a disconnection of the connections between the cerebellum and the opposite side inferior olive. And I failed to mention that these are connections that normally inhibit the olive. So they are inhibitory connections to the olive. So when you disconnect the inhibition to the olive, you would expect that the excitability in the olive is increased. And that's what we're seeing in this mouse model of SCA1, where there is no lesion in the brain stem, and there is no disconnection of the inhibition from the cerebellum to the olive, but nevertheless, there's an increase in the excitability of the olive. And this is related to some of the channels that Celeste mentioned, which are these calcium-activated potassium channels. So what do we think is going on mechanistically in HOD? We think that this disconnection from the cerebellum to the olive increases the excitability in the olive, which responds in this way by increasing its size and also generating this abnormal rhythm that then causes the oculopalatal tremor or oculopalatal myoclonus. Some recent reports suggest that there is, in fact, an overlap of the HOD phenotype even in the traditional spinocerebellar ataxias. So this was a report of 2 patients seen in South Korea who have radiologic changes of HOD that was not previously described in 2 individuals with spinocerebellar ataxia type 2, or SCA2. So again, what you're seeing here is a section MRI of the brainstem, and what you can see both on the top as well as the bottom MRI image is this characteristic area white increased signal in the region of the inferior olive in both these patients. And neither of these patients had oculopalatal tremor, but nevertheless exhibited signs of HOD. So just to kind of go over what the experience of the majority of patients that I see in my clinic who have a diagnosis of HOD, this is most often associated with a prior brainstem hemorrhage. And by brainstem hemorrhage, it's a kind of stroke where there's bleeding within the brainstem, sometimes associated with vascular malformations, such as what's called a cavernous malformation. There's a delayed onset. So oftentimes that initial injury that affects some of the cerebellar fibers causes ataxia, causes speech problems, and causes some tremor that's related to the ataxia itself. And the reason patients often see me is that there's a delayed onset of worsened tremor and ataxia far beyond what their initial ataxia looked like. In fact, some of these individuals, after the initial hemorrhage, would go on to rehab and do well, and then would have this really limiting tremor and worsened ataxia that necessitates kind of seeing a neurologist again. Sometimes this leads to confusion as to whether there has been a new event, whether there's a new bleed that's causing this worsened tremor and ataxia. I also see patients who don't have a history of brainstem hemorrhage and see it as part of a different neurodegenerative disorder, sometimes multiple system atrophy of the cerebellar type, sometimes multiple sclerosis with a demyelinating lesion, which is what's seen in multiple sclerosis in the brainstem, or a brainstem infarct, which is where there's blockage of a blood vessel rather than bleeding within the brainstem. So it's what is most challenging about HOD is how to treat these symptoms. And at this point, we don't have any approved agents to treat symptoms of the tremor and the ataxia that can really be quite profound and very limiting. Empirically, I do use agents that we use for tremor otherwise with some limited benefit. But I think some of what we've understood based on our mouse model, and if there's truly overlap between some of the membrane excitability changes that are seen both in HOD that's related to a brainstem hemorrhage and the HOD that's or the olivary degeneration that's seen in the spinocerebellar ataxias, there may be a way to target that membrane excitability by targeting some of these ion channels that are important for intrinsic excitability. And I do use agents based on some other work that we've done as an off-label treatment for the tremor and the ataxia seen in HOD. What is the natural history of HOD? And this we don't really know very, very well because there's very few reports. And I think there's a real critical need to understand the natural history of HOD better. Anecdotally, there is stability of symptoms with significant disability following the initial brainstem injury in many of the individuals with HOD who do develop tremor or ataxia subsequently. And in other disorders, such as MSAC, there's progression of the degenerative condition to extend to degeneration in brainstem regions that include things like swallowing that are worsened with disease, overall disease progression. So I'm going to stop there and hopefully give everybody enough time for questions. I want to acknowledge my laboratory researchers, including Logan Morrison, who's a Ph.D. student who is defending his dissertation this Thursday. And the clinic where we have two outstanding physical therapists, Janine Vincent and Agla Richards, who provide support. And I think it's a really important part of the rehabilitation of individuals with ataxia in general, and including HOD with worsened tremor and ataxia. Thank you.
Thank you for a fantastic talk, Dr. Shakkotai. We're going to be opening our Q&A period now. Just as a reminder, if you do have any questions for our speaker, please put them in the Q&A window at the bottom of your screen. If you put them in the chat, we may not be able to see them, and we want to get to as many questions as possible. And we already have some coming in. Also, as a quick reminder, if you have any questions for Christina as the head of the HODA, please feel free to type questions for her as well in the Q&A, and we can give them to her. So one question that was submitted ahead of time is, why is there such a significant delay between the moment the olive is damaged by stroke, surgery, etc., and the moment vestibular symptoms start? What's known about that for HOD?
Yeah. That's a great question. So we don't fully understand, but what we think is happening, and this is corroborated, I think, by some of the cat studies that I told you, where there's this disconnection between the cerebellum and the olive. So and this is still hypothesized because we don't fully understand the mechanisms by which HOD occurs. But what we think may be happening is that this is a compensatory response to this loss of inhibition from the olive to the olive. So the olive both gets information from the rest of the body to teach the cerebellum, but is also taught by the cerebellum as to what the cerebellum's needs are. And when this inhibition from the cerebellum to the olive is disconnected, the olive has lost some of its grounding, essentially, and it tries to potentially compensate by getting bigger and connecting more to each. Olivary neurons connect more to each other. So what and this process is delayed from when the initial connection happens, because as there's more learning happening, as more motor tasks are being performed, this kind of loss of inhibition to the olive allows, or it makes the olive respond in this abnormal way. And what we also think may be happening is when, and why only some patients with HOD actually also develop the oculopalatal tremor or the worsened ataxia, is that when the olive increases in size, it's both the size of the cells themselves, but how they connect with each other. So olivary neurons, like some other neurons in the nervous system, both receive input from elsewhere in the brain, but also talk to each other. And they talk to each other through direct connections at the levels of at the level of the dendrites through what are called gap junctions. So depolarization in one, or increase in excitability in one olivary nucleus actually can pass on to another olivary neuron within the nucleus if they're more connected at the level of the dendrite. And we think that when HOD happens, the olivary neurons hyperconnect with each other and then start generating a rhythm, which is the rhythm of the oculopalatal tremor, that then passes on to the cerebellum, which it's trying to teach. And the cerebellum is taught this abnormal rhythm that then it propagates to the rest of the motor system. And therefore, and that may also be the reason why the ataxia is worse, rather than being providing a useful teaching signal, it's providing this erroneous abnormal rhythm that then is a detriment to learning in the cerebellum itself.
Thank you for walking us through that. Our next question, are there any proven physical therapy exercises or techniques to help improve the vestibular symptoms caused by HOD?
Yeah. So and I want to kind of clarify that comment, because when we think about so some of the symptoms in HOD, such as dizziness, ataxia are channeled through vestibular pathways through the cerebellum, because the connection between the olivary nucleus and the vestibular system is really through the cerebellum, although there are some olivospinal tracks that influence kind of motor pathways directly. So empirically, some of the measures that are helpful for vestibular retraining in cerebellar ataxias can also be helpful in HOD. Vestibular therapy, in my experience, sometimes helps variably, but kind of agents that are used for tremor that may also target the vestibular system can sometimes also be helpful.
Awesome. And then our next question is, can trauma or a spinal cord injury impact the olive and thus cause ataxia?
Yeah, so I think it depends on because the cerebellum and the olive are so intricately connected, sometimes it's difficult to dissociate, and it's somewhat arbitrary anyway, to dissociate what the olive does separate from what the cerebellum does. An injury to the spinal cord, for example, that affects the spinocerebellar tracts, the tracts that go into the cerebellum, can also compromise the signals that the olive also sends to the cerebellum, and therefore can produce olivary dysfunction. So in general, though, injuries to the spinal cord, meaning below the level of the brain, the medulla, don't produce HOD. The most clear relationship between HOD, which is this hypertrophy of the olive, is when there's a disconnection of the fiber tracts going from the cerebellum to the olive in that whole region of the brainstem. So all the described cases of HOD really reside in lesions, or those that are associated with clear lesions, are in the region between the superior cerebellar peduncle, which is at the junction of the pons, actually the midbrain, and the lower limit is at the medulla, the top of the medulla, where the olive resides.
Thanks for clarifying that. We have a few questions about how HOD can relate to other forms of ataxia or movement disorders. So the first question, thanks for the lecture. For MSAC HOD, do you also recommend tremor treatment? Is there anything for the ataxia that can help improve symptoms?
Yeah, so I will admit that the treatment of the tremor and the ataxia when there is HOD is very challenging, and agents used for tremor are maybe it's very variable how effective and how much functional improvement there can be with those agents. But empirically, I do use agents that I use also for tremor in individuals with MSAC who exhibit features of HOD. Work that we've done in mouse models, as well as some off-label clinical use in humans with spinocerebellar ataxias. So we are pursuing kind of off-label use of muscle relaxants, which traditionally you don't generally associate with a treatment for ataxia, that at least anecdotally, at least in our experience, seems to help some individuals with HOD-associated worsening of tremor and ataxia, as well as the ataxia seen in some of the spinocerebellar ataxias.
Great, thank you for letting us know that. And then we have our next question. How is HOD related to SCA2? Could you speak a little bit about that?
Yeah, so we have very limited information. So the two case reports that I presented are what all we know really about HOD and SCA2. We do know, however, that olivary degeneration is a very consistent feature of SCA2, and SCA2 is also one of the inherited forms of OPCA, where there's olivary degeneration. So I think there's probably, as we learn more from the molecular mechanisms of how olivary degeneration, including HOD, happens, we will learn more about this relationship between how the olive integrates those signals from the cerebellum and is also affected by the mutation in SCA2, which is the repeat expansion in ataxin 2, to produce features suggestive of HOD. I will say that even the two reports of HOD in SCA2, there was not oculopalatal tremor, but the fact that olivary degeneration compromises some of the teaching signals for the cerebellum, I would expect that some of the ataxia seen in SCA1 and SCA2 is related to not merely the degeneration in the cerebellum, but the associated degeneration in the olive. And that's something we are continuing to investigate in our mouse models of SCA1.
Of course. And this, you may have partially answered this, but we have another attendee who's asking if SCA7 also has these features of HOD that you described, or if the vision problems seen in SCA7 have a different cause.
Yeah, so we don't know. SCA7, the natural history is much less well described because it is somewhat rarer than, say, SCA1 and SCA2. So there have been no reports of HOD in SCA7, but pathologically in SCA7, there is olivary degeneration. But we know that the vision problems, the actual loss of light perception in SCA7 is not related to the degeneration in the brain at all, but it's directly related to cone rod dystrophy, meaning loss of the light percepting neurons within the eye itself, within the retina itself. Whether some of the dizziness and the imbalance that and somebody mentioned kind of the vestibular type symptoms. Those symptoms are related to an additional olivary degeneration and the cerebellar degeneration in SCA7, which is also consistently seen, is not clear. But I guess the long answer or the short answer is the direct loss of vision in SCA7 is likely related to direct retinal degeneration. But some of the other ataxia and the other symptoms may be related to degeneration in the cerebellar olivary circuit.
Thanks for going over that with us. We have another question from an attendee who says, thank you so much for the talk and for sharing your current research and explaining HOD. Could you go over the off-label recommendations that you give to patients when they're exploring different treatment options for HOD?
Yeah, so I'm always reluctant to speak about kind of non-approved treatment options. So I think, and because I don't, I can't, in all scientific honesty, endorse what I use clinically. So it's a conversation that I have with my patients and tell them what the data are, explain the safety, and my own empirical evidence with those agents, but I would be uncomfortable talking about it unless I have a patient relationship with someone.
That's A-okay. So our next question is, it's two-parter. Does your discussion during this talk regarding tremors extend to worsening palatal myoclonus along with worsening ataxia? And then they clarified, their question is more in relation to the palatal tremor myoclonus in worsening tongue clicking symptoms, or does this research refer to all types of palatal tremors?
Yeah, so this is a really good question because sometimes the palatal tremor is a neurologic observation. It's not a driver of except maybe the clicking that a small subset of patients perceive. It's not a direct driver of the impairments that result from HOD. But the palatal tremor is a representation or a manifestation of abnormalities in olivary output that then impact the presence of tremor that elsewhere, as well as ataxia elsewhere, that's actually worsened by the development of HOD. So I think it's important to kind of parse out in some ways the two phenomena and how that impacts someone clinically. So although the palatal tremor is a reflection of a change in the olive that with abnormal physiology, that per se, in only a subset of patients, is actually bothersome in some meaningful way. But the association of that tremor can impact kind of breathing and dysphagia that, meaning swallowing, that is not really because of the palatal tremor per se. And I think the distinction is important because, for example, you could say, will kind of taking the palate, soft palate out or paralyzing the palate actually make a meaningful difference for some of the other things like speech and swallowing? And it likely will not, because that's really a reflection of something that's happening much more broadly in coordination of kind of muscle groups that are involved in swallowing and speaking that are controlled by the olivocerebellar circuit and not from the rhythmic movement of the palate per se.
Very good to know. Our next question is there any research being done on using TMS to treat HOD?
Yeah, so I will say that TMS, and just for those who may or may not be familiar with TMS, it's transcranial magnetic stimulation, which is a way to use an MRI machine, more or less, with magnetic fields to either stimulate or inhibit parts of the brain without non-invasively using an electromagnetic pulse. There's been limited use of TMS in individuals with ataxia, where there has been potential, and this is still, again, it's not an approved treatment. These are to be treated as anecdotal because these are really small reports, even if they're kind of done in a controlled setting, but where there's an improvement in posture and balance in individuals who have received TMS to the cerebellum. So the question regarding TMS for the ataxia or the oculopalatal tremor related to HOD has not been explored. So we don't know, but is there a biological substrate for TMS to potentially be helpful in HOD? I think you could make a case that it would be. What we think is happening is that the abnormal rhythm generated by the olive is directed through the cerebellum to the motor pathways. So TMS to the cerebellum with a protocol similar to what's been used in individuals with ataxia could potentially be justified, although we don't have any studies so far that have actually utilized the technique.
Sounds like more research is needed on that front. Our next question is, do you know if people with HOD have any problems with breathing?
Yeah, so the rhythm that is generated in HOD that's often in the eyes and the palate can also extend to the respiratory muscles. So some individuals with HOD, even without kind of the appendicular ataxia and tremor, have this trouble breathing because the tremor impinges on the normal rhythm of the respiratory cycle. So it doesn't cause lack of gas exchange because the pulmonary physiology itself is not affected, but induces a tremor in the respiratory muscles that can be quite impairing.
And our next question is also about symptoms. We have an attendee who's sharing that his numerous symptoms, balance, muscle tone, weakness, vision, dizziness, have been continuously worsening over 7 years, and it's gotten to a point where he's very exhausted. However, his neurologist is reporting that there's been no changes on his scans regarding the HOD. Why or what is known about why symptoms are continuing to worsen, even though the size of the olive doesn't appear to be changing, or
Yep.
it's stabilized.
Yeah, exactly. So, and this is, I think this also goes back to one of the earlier questions as to why there's a delay in the onset of symptoms regarding after that lesion that causes HOD. So this is a very hand-wavy explanation, and really based on this cat model of HOD, as well as some of the work that we've done in this SCA1 mouse model, in that the physical size of the inferior olive is just a reflection of a change in their activity. So it's the MRI or any kind of structural measure does not measure the activity in the olive. So what we think happens in the olive is, as HOD happens, they also connect with each other, generate this abnormal rhythm, and this rhythm is really ultimately what neurons do is they fire electrical impulses. So the structure of the neuron, while it's important in order to perform what they need to do, ultimately what a neuron does and what it tells the rest of the brain to do is based on what the electrical impulses it generates. And we think that HOD, particularly in cases where there's progressive changes, is related to impairment in the physiology, in the electrical activity that is then continuing to degrade the signals that are generated in the cerebellum, and how the cerebellum then instructs the rest of the brain to perform coordinated movements.
And then, speaking of coordination, our next question is, do balance exercises and other physical activity, can that help ataxia symptoms for folks who have HOD?
Absolutely. So, and I think the idea is that even though the signals from the olive are abnormal, there are the extrinsic signals, and by extrinsic signals I mean teaching signals through physical activity, through balance training, can help mitigate some of the learning that happens in the cerebellum, even in the presence of HOD. And just empirically, based on my own patients, having a physical therapist who really understands cerebellar ataxia can be tremendously helpful, including in patients with HOD-related ataxia.
Very good to know. Our next question from an attendee, is it plausible to develop bilateral ataxia when having a unilateral hemorrhagic stroke in the medulla, when only seeing olivary hypertrophy on one side of the MRI?
Yeah, so that's a really good question. And I also showed you some images in where there are brainstem hemorrhages. So our ability to pick up the changes in physiology on the MRI are obviously very limited. So just because you see HOD on one side and not the other, it doesn't mean that the changes of abnormal rhythms in the other contralateral olive are not happening. So the way the tracks to the olive descend into the medulla are that they are very closely placed and next to each other in the medulla. So the way the tracks to the olive go from the cerebellum to the olive it exits in the brainstem at the superior cerebellar peduncle, which is actually at the level of the midbrain, and considerably higher level than where the olive is located. And then these fiber tracks, for reasons unknown, then descend all the way down to the medulla, and then connect with the opposite olive. So, and the central tegmental tract, which is the tract through which these fibers traverse, is fairly close to the midline in the medulla. So even if it's, and there's not a there's a lot of real estate in a very small area in the brainstem. So what looks kind of clinically to be more asymmetric can still impinge on fiber tracts that are descending from both sides. So I think what my kind of more abbreviated explanation would be is that even though you're seeing the HOD from the hemorrhage on one side, there's likely involvement of the other side, maybe not to the same extent, but and therefore not visible as HOD on the MRI.
Thanks for explaining that. We have time for about one more question, and I'll pose it both to you, Dr. Shakkottai, and well as you, Christina. If people want to get involved with HOD research, what are some ways that they can stay connected to the HOD community and get involved with research that is local to them?
I'm going to let Christina answer first.
Thank you. I was going to mention that we do have a patient registry with Sanford Cords. So if you do have HOD, please go over to Sanford Cords, which is where NAF houses their registry as well. And please participate in the HOD registry. We are not aware of a lot of research projects. Dr. Shakkottai probably knows more about that. At this point, once we have a robust registry, currently we only have 40 participants. We are looking to get some funding for a mouse model for HOD specifically, and for we're also going to be looking for that natural history study that Dr. Shakkottai mentioned that we just don't have yet. So please help us participate there. We also, HODA last week had a great webinar about brain donation. You can go to our YouTube channel and find that. It's pretty short, maybe 50 minutes or so, about why it's important to donate your brain to science to help us learn more. And to keep up with us, you can go to our website, which is www.hodassoc, so hodasoc.org. We also have a Facebook group. We're on most of the socials. We are not on X. I refuse to get on X. That is my prerogative. Anywho, yeah, so there's a lot of potential for some great research to get involved with. We just need to do the groundwork first, which is what we are working hard to do. Dr. Shakkottai?
No, I would agree. I think there's so little knowledge, even among neurologists, about the relationship of HOD, the imaging findings, and what the natural history is. And I think it's really important to understand more about the natural history of this condition, both in individuals who have a lesion and others who have kind of more progressive ataxia with a palatal tremor syndrome, which may represent a different kind of etiology, but may still provide some convergence in terms of mechanism.
Well, thank you both so much for joining us today. We weren't able to get to everyone's questions, so please feel free to reach out to NAF or the HODA to follow up on those. So thank you, Dr. Shakkottai, so much for sharing your expertise with us. We really appreciate it.
Thank you. It was great being here.
And thank you, Christina, for joining us on this joint session. We really appreciated learning from the HODA on this topic. And thanks for all of you for attending and learning a little bit more about HOD. I hope you found something valuable from this session. And wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful rest of your day. Take care, everyone.